Welcome to this webinar on enhancing healthcare efficiency. And I'm very pleased to have here as our guest speakers two very known distinguished radiologists, leader in the breast imaging field, Dr. Athina Vourtsis from Athens and Dr. Teresa Presa from Madrid. And I am Dr. Iris Alabeo. I'm an academic breast radiologist from the University of Cambridge. My main work is focused on early detection of breast cancer with supplemental imaging and AI tools. And then I wanted to, before moving to our speakers, just wanted to make a brief summary of what ultrasound and the importance of breast ultrasound in the imaging and the detection of breast cancer. As I'm sure you all know, ultrasound is a key modality for imaging breast for diagnostic and screening purposes. It is the first modality that we use in investigating palpable lumps in the breast, as well as abnormalities that we find in screening mammograms or MRIs. And recently, ultrasound has been used increasingly for screening women with dense breast. As we know, the sensitivity of mammograms in this category is dropped significantly, less to 60%. And ultrasound helps to detect more cancers compared to mammography in this category. So I would like to start the webinar. Before, I would like to explain the question and answer section and the discussion. We will do it at the very end, after we will hear both of our speakers, their talks, and I would invite you to put your questions into the QA section. You could see it on your screen. You can write them down, and then we can discuss them at the very end of our webinar. Okay, so I'll introduce and welcome our first speaker then, Dr. Athina Vourtsis, which is said a very recognized experienced breast radiologist, leader in the field of breast imaging, especially in supplemental screening, and also a quite broad experience on automated breast ultrasound and handheld ultrasound and AI implementation in ultrasound technology. She is chair of radiology at Athina Medical and founding president of the Hellenic Breast Imaging Society. Her presentation today will be on enhancing efficiency with AI and automated breast ultrasound. Dr. Athina, please, the floor is yours. Looking forward to it.
Thank you so much for your kind introduction. So hello, everyone. We'll talk about AI and automated breast ultrasound today. So just some background about the importance of supplemental screening. So why we actually need to do additional imaging to add to mammography, additional imaging modalities. It is the fact that women that have dense breasts have an increased risk of developing breast cancer. And the risk varies between 4 to 6 times higher than normal than other women. And also the sensitivity of mammography in this target group is lower. And we'll see in this slide here that in women that have extremely dense breast, the sensitivity of mammography varies between 57 to 71%. This actually means that from 100 cancers, about 39 cancers can be missed in this group of women. How about women that have heterogeneously dense breast? Also, the sensitivity is lower and it varies between 70 to 81%. So this group of women need additional screening. And we know that breast ultrasound has been around for many years, over 50 years. And we have with Dr. Wendy Burke from Pittsburgh. We have evaluated over 400,000 examinations where we found that handheld breast ultrasound detects approximately 3 cancers per 1,000 women screened. And ultrasound, it lowers the interval cancer rate. It is usually not affected by breast density. However, by using ultrasound these years, we have realized that it is an operator-dependent technique, and there is inconsistency between scanning from one physician to the other. Also, there is reduced reproducibility of images. We have small field of view. The images are static. We cannot do any post-processing. The examination is time-consuming. We need about 15 minutes to scan a medium-sized, 2 medium-sized breast. And there's a lot of conversation about the high recall rate and the false positive rate. And this is actually the reason why automated breast ultrasound has been developed. This is the automated ultrasound suite. This is how it looks like. And the advantages of automated breast ultrasound is mainly that it is a standardized and reproducible technique. You can see here how the scan is performed. We scan after spreading out evenly throughout the breast, a hypoallergic lotion. The scan is performed from the inferior part of the breast, going superiorly up to the area just below the clavicle. And then there is a special software that actually you can we reconstruct the images are reconstructed. So the raw image, the transverse image, this is the one, and this is a mass located over here, is reconstructed into the sagittal and the coronal. It means that we're able to see every part of the breast in 3 different planes or 3 different aspects. We have post-processing capabilities. We can do double reading because we do not have just, static images. You can see here the video. And according to Professor Frauenfelder from Zurich, the examinations, besides being standardized, it helps to improve quality and producibility. You can see through the years from 2017 up to 2023 how much more the Abos examinations were increased compared to handheld breast ultrasound. Now that we know that AI is everywhere in our daily life, the same thing also in various imaging modalities. So AI has been integrated for 2D mammography, for tomo, for handheld breast ultrasound, and we have a lecture. The next speaker will talk about that, and also in automated breast ultrasound, as well as in breast MRI. But why do we need AI for Abos images? Actually, we have large volume. We have a lot of images. It means this gets our eyes tired. Also, it can improve our specificity by decreasing the presence of artifact. We can better evaluate the image quality, and also we can decrease with AI our reading time. And we should not forget the radiologists are the most mentally, I would say, heavy workload physicians because we see so many images during the day. Now, the new Abos houses AI features, which ensures that the entire breast volume is captured. So besides detectability, which means that we use AI to detect and characterize a lesion, now AI is able to help us to ensure that the entire breast volume has been captured with the acquisitions that it has been included in our field of view, that in the images that we receive in our workstation. We have automated nipple annotation. The scanning time is reduced by 30%, and also there is a great improvement on image quality. And we know that it depends on the experience of different technicians. We have 3 different technicians in our facility, in our breast department here. They perform differently. The more advanced perform, they are faster, and also their images are more perfect. So now we have a scan quality assessment software on the system, which actually by itself evaluates the depth, also evaluates the coverage, and you can see here that it gives us the information that the entire part of the breast is included in the field of view of the images. And here is the same patient where Abos was performed with Abos 2.5, the premium, the most recent model, and this is the previous installation, where you can see the difference on image quality. There's more artifacts on the previous model. Here you can see the sharpness of the image. This is the same patient on last year's exam and this year's. Now, how does AI works for detectability? Actually, there are different systems, there are different softwares that have been already developed. You can see that there is lesion segmentation, then we have feature extraction. This is how the model is built. There is validation, there is performance. And this is used for lesion characterization. But now we have also deep learning, which the entire software works by itself. It mimics like human brain, and it is has fully connected layers. Now we have been working with AI for approximately 6 years. How our AI system works, it is called QViewCut. It's a QViewCut software where automatically it extracts features. It generates a score for each suspicious area that is larger than 5 millimeters. The descriptive features that the AI uses is the boundary, the region boundary, the margin pattern, the orientation of the lesion, the posterior enhancement, presence of architectural distortions. It means that these are all the descriptive features that we also use for our readings. Then the training algorithm employs a cross-validation technique to achieve optimal performance, and this system is used for concurrent reading and not as a standalone tool. And this is how the image looks like. There is an area, a dark spot. You can see that it is circle with green. These images are called minimum intensity projections. This is another patient. There is a suspicious small tiny cancer in the upper outer portion of the left breast. You can see that it was marked. And this is another patient with the most recent Abos unit. You can see the area of suspicion is marked in all 3 planes, the transverse, the sagittal, and the coronal. What clinical evidence we have? There are a couple of studies that have shown. This is a retrospective study that evaluated the performance and reading time of automated breast ultrasound with or without AI. And it showed that both beginners as well as advanced readers, that it was very helpful by reducing the reading time by 30%. This is a new 3D, new AI system that was published by WFUMB in 2019. They evaluated the cancer detection rate in patients that had performed Abos, and the detectability rate for cancers that were less than 1 centimeter large reached up to 86.4%. So I would say that it is quite good. Now, some results from our experience, where we included 160 patients that had dense breast. Among these patients, 20 cancers were seen only with CAT and not on mammography, neither on DBD, where the sensitivity rate was up to 95%. It means that CAT detected 19 out of 20 cancers that were hidden in mammography. Some illustrative cases. This involves a 69-year-old woman. She had ACRC pattern, no family history, where we see an asymmetry in the upper outer quadrant portion of the left breast. It's not obvious on the CC projection. On Abos, you can see the area that has been circled by us. You can see that it is an indistinct hypoechoic mass associated with acoustic shadowing this a BI-RADS 4 finding. These are the post-processing images, and this is the correlate of the AI. And this was a small invasive grade 2 invasive lobular cancer, grade 2, measuring 8 millimeters. Our second patient is 44-year-old. She did not have any related personal family risk factors. Clinical examination was negative, and we do not see anything on her DBD examination. These are slices on CC projection. However, in her ABAS volumes, this is the AP, and this is the right inferior volume, where is an irregular mass. You can see here the irregularity of the lesion. And this is her AI correlate images. And this was an invasive ductal measuring, again, 8 millimeters, very small lesion. Our next patient is 48 years old. You can see here that there is a focal asymmetry, but this represented just a small cyst in the left breast. She is heterogeneously dense breast. The lesion is located in the inferior part of the left breast, and this is the coronal, this is the sagittal, and the transverse plane. In all three planes, we recognize an irregularly shaped mass, and this is the correlate of the AI image. This is the minimum intensity projection. And this is from previous year. There was nothing in the previous year. And this was an invasive lobular cancer, less than 1 centimeter. There are several limitations that I would like to present for cancer detection using AI with ABAS. It was quite difficult to detect these cancers because many times there are some artifacts and shadows, which causes deformity of the breast tissue. And therefore, sometimes the shape of the lesion, the contour, are not so clear for the system to recognize suspicious lesions. Also, some cancers may have similar appearance as the normal hypoechoic structures and benign lesions. Therefore, many times benign lesions from cancers are not distinguished with AI. Also, subtle cancers, very tiny ones, can be dismissed. Sometimes the image quality of ultrasound is not so great. Also, the developed detection method using machine learning approaches could be inaccurate. So all this can happen. I can show you some images from our facility. You can see there are two areas. First, second area, they have been encircled with green. They're supposed to be suspicious for the AI, and also one area in the left breast. So one in the right, the upper area, was just deformity due to post-operative changes. The second was artifact, whereas in the left breast, it was an invasive lobular cancer. In this patient, we have multiple circles here. Which one is, if any, suspicious? You can see the large one up here. It corresponds to a hypoechoic mass. This was a triple negative cancer, where the rest three circles, the black spots, were just due to simple cyst, were just simple cyst. And one more patient. This is, you can see a small cyst, but the AI cannot distinguish cyst from circumscribed masses. This is a real cancer, tiny mass, which was also found with AI. So the difference of the ABAS image, if I can go back here, you can see that the ABAS image is quite different. You can see more gray tissue, whereas with AI, the pattern is different. We have the navigator image, which is like minimum intensity projection, and everything looks more grayish. Therefore, whatever is dark, it is just pointing out, it is more obvious. We need further large prospective trials in order to have more validated results. Also, we have to have more information about our collaboration between physicians. So if we have an AI, is it necessary to also have another radiologist for second look ultrasounds? I'm not sure about that. There are ethical constraints and limitations that need to be discussed. There are legal issues that need to be covered, and also the cost effectiveness. And of course, a successful AI tool could be reliable in the future, could be able to recognize benign from suspicious lesions, also could distinguish post-operative changes and not mark, not have a lot of marks that we have to go through every single one and make sure that it does not correspond to a suspicious lesion. Also, the integration of radiomics in detection and characterization, and maybe for staging and response to treatment will open a new horizon in our field. So briefly, ABAS improves productivity. It saves our time from scanning, and also it allows us to benefit from spending more time to focus and speak to the patient, and also to do other readings. The new unit provides AI features for scan quality assessment with decrease on acquisition time by 30%, and also there's an improvement on image quality. Now, the AI systems that are available in the market are also reducing the reading time, which is extremely important. When we are low, we have a lot of work, it improves the workflow because by just spending less time in each examination, if you're more confident, this is extremely important. And also be able to go back and do the reading separately. If you do double reading, this is also another advantage. And here is our automated breast ultrasound textbook for screening and diagnosis with co-authors, Dr. Ellen Menderson and also Dr. Georgia Spear from the USA, which was launched last year, 2024, at RSNA, and hopefully will be available in the SOFs by the end of this year, for those of you that are interested. Thank you so much.
Thank you very much, Athina, for this excellent presentation. I would like now to invite Dr. Teresa Presa for her talk on enhancing breast ultrasound accuracy using AI to reduce BI-RADS 3 lesions diagnosis, right?
So good afternoon, everybody, and thank you for the invitation to share my experience and my opinions on AI on ultrasound with the aim of reducing BI-RADS 3 lesions. So, as a way of introductions, we consider a BI-RADS 3 lesion in all different imaging techniques to that lesion that is considered probably benign. When we say that, we are meaning that there is less than 2% of likelihood of malignancy. So these lesions require a short-term follow-up. First one, 6 months, the next one after the 6 months, that would be a year, and a third and last follow-up scan or mammogram or MRI 12 months later from the very beginning. The BI-RADS 3 was described decades ago, and the aim of these classifications was to reduce false positive and therefore unnecessary biopsies, but also the aim was to avoid delays in breast cancer diagnosis if we were considering benign lesion while they were not benign or malignant. But even this is clear and properly written on the BI-RADS, sometimes BI-RADS 3 is misapplied. So if we go to the BI-RADS lexicon and we concentrate on the ultrasound scan, we see that BI-RADS 3 are considered lesions like these ones. So they're oval and circumscribed and parallel solid masses, complicated cysts like the ones we can see below. So it's a cyst with some content, or a cluster of cysts or cysts with septi, or some cysts with content, and also the clustered microcyst. Why do I say that sometimes BI-RADS 3 is misapplied? So we can misapply BI-RADS 3 in different setups. So first, we can consider a malignant lesion as benign or probably benign, and subject the lesion to a certain follow-up, mammographic or ultrasound follow-up. But also we can use BI-RADS 3 as a first diagnosis on a screening mammogram, and that's a misused, because we shouldn't use BI-RADS 3 on the first screening mammogram. And if we read the BI-RADS, we can see that there is an auditing and outcome mentoring. Then we can read that we should audit all our initial category 3 assessments, downgraded to category 1 or category 2 in the first ultrasound, meaning that we interpret as a lesion something that it wasn't. So we want to ensure an optimal outcome of the patient, first to reduce cost effectiveness, second to avoid patient anxiety. We are telling the patient that something is good, so we're telling the patient your first ultrasound is good, don't worry about it, but precautionary, we are going to follow you in 6 months. So that sometimes creates a little bit of anxiety on the patients. But one of the most important things we have to take in mind is that radiology is facing a global shortage. So unfortunately, or fortunately, we are doing more and more imaging on women, not only ultrasound scans, but mammograms, MRIs, contrast-enhanced mammography on one side. And on the other side, we have a radiologist shortage. So there is a mismatch between the number of radiologists and number of imaging tests. We can see here this graphic that I found last week, where we can see how the radiology workforce is growing very little, and how the number of CT, MRI, and we can add here ultrasound scans and mammography is increasing. So we have to make follow-ups count with process, people, and artificial intelligence. So here is my point. How can artificial intelligence can enhance our ultrasound accuracy? So how can artificial intelligence make us better radiologists? So I work in my hospital with the artificial intelligence integrated in my ultrasound scan. In my case, I use kiosks. So while I'm doing my ultrasound scan, I can, at the same in the same act, while I'm talking to the patient, put my AI and ask their opinion. And usually how I see the opinion of the AI is one of these graphic. They give us the opinion and they give us the BI-RADS of the lesion. And it can be a BI-RADS 2, 3, 4, or 5 as we use normally. So how can AI help us on ultrasound? So first of all, AI can help us to improve lower performance. Why lower performance? We know that breast ultrasound, as my colleague Athina said, it depends also in your expertise. So we know the experienced radiologist has usually a high sensitivity and a good accuracy. But if we go to a least experienced radiologist, meaning with less than 5, 6, 7 years of experience, the sensitivity drops to 84% and also does the accuracy. But look at this. If we give the AI to a less experienced radiologist, the sensitivity goes up, still a little bit below of the experienced radiologist, and also the accuracy. So we are giving a tool to a less experienced radiologist to help and improve their accuracy. On the other hand, we can reduce unnecessary biopsies. So kiosks, in this article that was published in 2025 in the European Radiology, show that can significantly reduce the number of unnecessary biopsies. If we are reviewing the accuracy of a senior breast radiologist, we can see a reduce in the number of biopsies from 46% to 33%. But this difference is bigger, is wider, if we go to a junior breast radiologist, where we can see that from the beginning, he was asking for a 51.7% of biopsies, and with the help of the artificial intelligence, the number of biopsies reduced to 32.6%. So AI can also reduce the unnecessary biopsies. And what about the follow-up? That it's the aim of this talk. So here, last year, we saw in this 2024 that in a study that review, it's a retrospective study, I know that, but they reviewed 715 breast masses, and they realized that none of the lesions categorized as BI-RADS 2 by the AI are safe, and we can give a BI-RADS 2 lesion. So we can give a BI-RADS 2 to the lesions. We are safe to consider the AI opinion. So if we put all this together, we have the radiologist, radiographers, more experienced radiologists, less experienced radiologists. We, as radiographers and radiologists, have the clinical information, so the patient demographics, we have the mammographic appearances of the lesion, we know the symptoms or the absence of symptoms, and we have previous images. With all this, and with the aid of artificial intelligence, we can increase the number of BI-RADS 2, we can decrease the number of BI-RADS 3, and therefore we can be more accurate when we decide to biopsy a BI-RADS 4 or 5 lesion. So here I'm going to put some examples. So these are examples from my daily practice. This is a 51-year-old, and this is the first screening mammogram. The woman was recalled for a lesion on the right upper outer quadrant of the right breast. You can see the lesion has obscure margins. So one of my colleagues was doing the ultrasound, and she found this lesion. So it was a well-defined parallel lesion to the surface or to the skin. So I think most of us as radiologists, we consider this lesion as benign, but the woman was 51. We didn't have anything to compare with. In our setup in Spain, we should put this woman on the BI-RADS 3 follow-up. But what happened if we ask KIOS, what do you think about this? And KIOS gives us a BI-RADS 2. So they say this lesion is benign. So we have the opinion of our experienced radiologist, the opinion of artificial intelligence. So let's move. You can tell the patient you have a benign lesion on the breast, and you can carry on with your normal follow-up in 2 years' time. Other different setup. This is a 37-year-old woman. This is the first ultrasound scan. This was one of my trainees doing the ultrasound. She found multiple well-defined lesions in both breasts. And you can tell me, okay, this is a BI-RADS 2 based on BI-RADS, because BI-RADS says if you find more than 3 lesions in both breasts, you can consider them benign. But my trainee thought this lesion in the lower outer quadrant of the left breast wasn't completely well-defined. She thought it was maybe lobulated, etc. She used our KIOS system, and the KIOS said, oh, don't worry, this is also a benign lesion, so this woman shouldn't be follow-up. What about dense breast? Dense breast, and we do ultrasound on some women. I was talking previously with Iris. We don't do normal ultrasound on our dense breast. We hope so, but we don't. But on different setups, if the woman complains about breast pain or something else, we can complete the mammogram with an ultrasound. So we found these kind of lesions. All of you again would think this is a benign lesion, well-defined, parallel to the skin, etc. But first mammograms, dense breast, sometimes you need a reassurance. Here it is, the reassurance, BI-RADS 2. No worries, you can tell the patient she has a fibroadenoma and she can move on to next follow-up. This maybe is a little bit more complicated because it was slightly bigger, but same setup. So first 51-year-old, first screening mammogram. I didn't put the other breast because it was completely normal. So we see a well-defined lesion in the right upper outer quadrant. This is the appearances on the breast. The KIOS opinion is again a BI-RADS 2. So we can tell the patient same things. I have here, don't think that the artificial intelligence gives all the time a BI-RADS 2. We wish sometimes it gives you other opinions. Here, kind of similar patient, first screening mammogram, well-defined or obscure margins nodule in the upper outer quadrant, and we scanned the patient and we found this. This is a well-defined lesion, again parallel, but it has some levels. So what we do now, so we ask somebody to help here, and sometimes the kiosk says, oh, this is suspicious. So we biopsy that lesion, and it was a benign lesion. It was a benign fibroadenoma. So with this, but I do agree with the artificial intelligence here that this lesion should have been biopsied. And my last case here, it was a good recall because it was just on the edge of the picture. You can see a little lesion right upper inner quadrant on the MLO. We can argue if it's a well-defined, but here you have your doubts. We ultrasound the patient and we found this little lesion, not as well-defined as the previous one with irregular margins. We as breast radiologists, experienced breast radiologists, I don't think we have any doubts what to do with this, but we have some colleagues who are not as experienced. We have trainees who are not as experienced, and we can give them some aid and tell them, no, look, this is a malignant lesion. It should be biopsied. So just to finish, some take-home points. So I think with the support of the AI and meaning, so we have a breast radiologist who is asking another opinion, we can reduce the number of BI-RADS-3 assessment, we can decrease the number of unnecessary biopsies, and of course, we can avoid misdiagnosis of breast cancer. And thank you very much.
Thank you very much, Dr. Teresa. I forgot to introduce at the beginning, Dr. Teresa is an very experienced lead breast radiologist with more than 15 years of experience working both now currently in Madrid, but also been working in UK. And she is currently serving as the breast screening lead at the University Hospital, as you could see here in Ramon, right? Yeah, Callao in Madrid.
Ramon y Cajal, yes.
Yeah, sorry for my pronunciation. My Spanish is not
That's okay.
that great. But yes, it was very interesting, both very interesting presentations. I agree, AI could definitely help with the diagnostic performance of ultrasound, both in diagnostic and screening setting. With the ABAS, obviously, a combination of both detection and decision support tool would be ideal in a screening setting, as Athina was mentioning, but also in the diagnostic setting, tools that support the decision and help to improve the performance of the junior radiologists are quite useful in the clinical practice to avoid those unnecessary biopsies and unnecessary follow-ups. So I think it's quite it's the way to move forward and to make ultrasound more useful and more integrated in the clinical practice. I don't know if you agree. There is a question on from the chat from one of the participants. It says, who shall do the ABAS post-processing? I think it might answer this question.
Yes, so thank you, Iris. So post-processing is done by radiologists. So during the reading, it is so easy with a mouse to do any post-processing in different planes and transverse and sagittal to enlarge the image. So it is extremely easy, and we do it by ourselves. It depends when we feel that it will help us further to see better if there is any area of concern. Also, we use a tool that it helps us to differentiate real artifacts, real shadowings from real lesions. So I would say the post-processing is extremely easy, and it is used by radiologists who are doing the reading.
Yeah.
So Athina, can I ask you something? How long does it take to do a post-processing? once you have the experience, I
Let's
guess
see.
this is how
Post-processing,
long?
just a few, how much time?
Yes.
The reading or just post-processing?
Well, everything all together.
I would say normal reading, it takes me 3 to 5 minutes.
Yeah, I would share also our experience here in Cambridge. We used ABUS for research purposes as part of the BRAE trial, which was a large multicentric trial looking at the feasibility of supplemental imaging on women with dense breast. And we started, there's always a learning curve. The beginning, it took we had long reading and post-processing times for ABUS especially in the first 6 months, but then that with experience, it got reduced significantly to 3 minutes. So we were majority of our readers were able to read the whole exams into 3 minutes. I mean, the average reading time, which is quite good. And I was hearing a talk of in Athina's talk that with the new AI detection, this could be further decreased. I mean, studies which is quite promising. So it's definitely it is important, because if we consider to implement ABUS as a screening tool, it is crucial to be, I mean, the length reading times are quite problematic for high volume centers. So we have to make it more efficient. So definitely
Yes.
AI would be something that could help with that. Well, I agree. I think so. Yeah. Excellent. So let's have a look if we've got a question. Is there a study comparing false positives and recall rates of AI, ABUS, and mammography using AI? So the question is whether there is any study that is comparing these two modalities and the recall rates and false positives. Yeah, I guess it's.
Well, I'm aware of a study that has combined AI readings of ABUS and mammography. It was, I don't remember where it was published, but I read it just a few weeks ago.
Okay, so now we started again. Sorry, there was an interruption.
Yeah.
So I've seen
Yes.
that publication as well. I can't remember, but it was a combined model that was combining AI and mammography. So both AI used on ABUS and mammography, and that's obviously the combined tool had the best diagnostic performance.
Yes.
Compared to AI, ABUS, and mammography using AI. There are studies, ongoing studies, that will be more, hopefully. So, yeah, I can't remember that study as well. Well, probably if I do.
But I do not have any information about the false positives and the recall rate of AI with ABUS. I don't think there is a study that has
a comparative
evaluated,
study,
yes. At least not yet.
Really, yeah. So it's a good idea for a study.
It's a good idea.
Could be, yeah.
It's a great idea for a study.
Excellent. So next question would be, multiple bilateral circumscribed breast masses in age 45 and 55 years, first time on ultrasound, can use BI-RADS 2 in age 45 and use BI-RADS 3 in 55. So if I'm not sure whether I understand. So so we've got bilateral circumscribed breast masses diagnosed, and one of the ladies is 45 and the other one is 55. How would we categorize this?
So I don't think BI-RADS gives any age limit. So I think you have to check the lesion. So you have to see that the lesion is benign. So it's well-defined, circumscribed, parallel to the skin. And it doesn't matter the age of the woman. So if there is more than 3, you can give a BI-RADS 2 and don't follow them up.
Yeah.
Yeah. But sometimes it's difficult. I get the opinion, so I get the why is asking this, because sometimes when your level of suspicious is higher when the woman is older. So yep, that's why one of the scenarios that the AI can help you to make decisions.
Yes, definitely. In UK, we've got the protocol, the standard protocol is women which are, probably because they've been are younger than 30.
I know it's a bit
Then
different.
then if it's a BI-RADS 2, even if it's a well-defined fibroadenoma, you can leave it. But if they are above 40, then even if it looks very benign, you will need to biopsy it. So it's I agree. Probably AI would just solve this unnecessary biopsies and follow up.
Especially those ones all of us think is a benign lesion and it's clearly benign. Why do we have to biopsy? I think those ones are there.
Yeah,
I just want to add that, particularly in this patient, about this question, I would take into consideration the personal and family history before deciding. On the other hand, we know that having multiple circumscribed masses bilaterally, the chance of being malignancy is less than 1%. There are several studies. One of them was published by Dr. Windyberg. In my situation, in my practice, if there is no family history and no other associated risk factors, I will follow this patient once after 6 months to make sure there is stability. And after that, I'll just release the patient for an annual screening.
Yeah, I think
yeah, I think there's some
important.
studies. Yeah, there's some studies in Spain ongoing about doing just one follow-up ultrasound on BI-RADS 3, and if the lesion is stable, just stop and not doing the following up, because we have, if we think about it, most of the lesions that are malignant will increase in the first 6 months.
Yes.
But that's something still we don't have enough evidence to do that. Or I think if you follow the BI-RADS, that's what it says.
Yes.
Yeah. Okay, so there is another question, very futuristic. While looking ahead, do you think that AI is going to capture and do or replace completely the breast diagnosis, and we will not need any radiologists? I think for the ultrasound, this might be a bit tricky, but yeah, I'd like to hear your opinion.
So I would love to hear your opinions too, because I'm sure you've worked a lot with AI, but I've recently been working with AI on mammogram for the last 6 months. And I think at the moment, with things like now, we are far away from being replaced because there's still a lot to be done. So it's not, not saying that is good and it helps, but that's the key. It helps. I don't think it can work.
It can totally replace. Yeah, I think I agree. We're a bit far from that point. In the near future, the tendency of AI now is to support the decision support, and also to act as a second opinion or a double reader, and exclude the normal mammograms or normal ultrasounds, or reduce the workload. That could be potentially the majority of the AI use in clinical practice, but I don't think it will replace soon our work. We still need to be around, because there are, AI is good for high volume, so as we said, could reduce workload, but still there are fine things that the human minds needs to address, that AI, regardless of the improvements, cannot address 100%. But we don't know whether this will happen in the future. But for the moment, I don't think we have to worry about that.
No.
Yeah. We still have a lot of work to do.
We still have a lot of work to
Yes.
do. If it helped us to, with those benign lesions or those women, that we can concentrate on the other ones. So I think there's still a room for both of us. Yeah.
Yeah. And well, there's another question. Based on your experience, I think it's more for Athina, have ABAS helped on following up lesions with, means saying here, changing BI-RADS category? I mean, in terms of upgrading or downgrading them. So has ABAS helped with this, or
yes,
ABAS
this
plus
is,
AI? I don't know.
yes, this is very interesting. I would say that in some specific patients, it has helped us to upgrade lesions that seemed less suspicious on handheld, but appeared more speculated or, showing the distortion on the coronal image. So there are like couple, 3-4 patients, I would say per year, that it did help us a lot to make a decision instead of BI-RADS 3 to go directly to BI-RADS 4 and do a biopsy, and it proved to be a cancer. There are several patients, I think there were more than 2 that had radial scars and they were not cancers. So it is interesting. In this aspect, the multi-reconstruction images can be more helpful. Now, there are several studies that have shown that there is downgrade if there are less biopsies performed by using ABAS, comparing only handheld breast ultrasound.
Yes, that's very interesting. We have seen it in our from our experience as well. And ABAS really helps with those tiny lesions, especially the coronal plane, the distortion. We've had cancers that were picked up because our population was screening population with normal mammograms. But we picked up those cancers only on coronal images. And then we went retrospectively looking at the tiny, and we correlated 5mm cancers. And the advantages of ABAS compared to held ultrasound is that it's reproducible. So you could compare with the previous ones. And we've had exactly the same as you, like radial scars that look very scary. But when you go to previous exams, they are unchanged, like we do with mammograms. So this is an advantage of ABAS from handheld ultrasound. You can see the whole examination and correlate exactly the same place. And we for follow-ups, that's important. If it's unchanged, then we just leave it. So if it's a BI-RADS 3, then you can, and it's unchanged as we do it with other follow-ups, then you can leave it and downgrade it to BI-RADS 2. So this is one of the benefits of ABAS compared to handheld ultrasound. It can be directly comparable.
Yes, and more accurate, more precise comparison can be made. Even in follow-ups of multiple masses, it is easier to compare masses, one view by the other, next to each other, than, just by marking the lesion, measuring the lesion on handheld.
Yeah.
This is one of the advantages, actually. Yes, I agree.
Yeah, it is quite. I think there, well, there is not, it's not more like thank you. And they're asking whether we could share the AI protocols and the studies. So I don't know whether we could share those links or, but I mean, Athina, are we able to share any slides of the presentations or any?
Yes, they can let us know what they need.
So maybe you can email if you're interested in more detail about the studies or the protocols, then they can email you directly, right?
Yes.
Okay, excellent. And it's a question. I think this is the last question. What is the benefit of ABUS in differential diagnosis of fat necrosis? Is there whether there is any benefit?
Actually, there is not a great benefit in differential diagnosis. Those are post-traumatic changes, and they're easily recognized with mammography and DBD. Now, the benefit I would say that you have in oncologic patients is that during the follow-up, you have more accurate comparison between previous and current examinations. So, you know, if there is any change, you can notice right away. So in this aspect, yes, it is helpful, but we do not ABUS does not allows us to evaluate vascularity as we are able to do with handheld breast ultrasound. So if you have a relapse in the area of the scar, it's of course easier to recognize it and to differentiate post-traumatic necrosis with vascularity. Therefore, you have to use handheld breast ultrasound.
Yes,
I think all of you agree.
Yeah, I think the key is to go and check the mammograms as well, because they will be complementary.
Yes.
Of the diagnosis. Okay. Do you want to add anything else to the discussion? I found it personally quite very, very nice and thought-provoking, insightful, this presentation. Excellent talks, and it was great to hear both talks, both of you, your experience, share your own experience, both on ABUS and handheld ultrasound and with AI integration as well. And well, I would like to thank you again for your talks.
Thank you very much.
Time. And I would like to thank you all the participants for joining.